Welcome to Mad Medicine with Miss P. I am Miss P. Good to see you again. Okay, so today we're going to do assessment, and my camera should not shut off. I think I have that all taken care of. Apparently, there was a whole lot of extra crap on my phone, so it ran out of memory. That's because I have a Droid from I don't know, 2015. I know I need to upgrade. I'm going to. One of these days I will. At any rate, um, sorry, last week you missed your pet peeve, but that was one of my pet peeves, my camera shutting off because I refuse to upgrade. And no, I'm probably never going to go to an iPhone. I'm not spending $1,000 on something I could easily break and probably will. So just, we're going to deal. So we're going to do assessment today. Now, especially for you nursing students, and some of you nurses on the floor, I know that it seems like you just kind of do what you're told. You know, your instructor says, we ask them this, we tell them this, we check this, we, thump on this, we listen to this, and then we write it all down. And then by the time you get to me, I realize you don't know what any of that means. It's not that it wasn't taught. It's more that it was taught kind of quickly and all at once, and maybe we didn't really slow down to understand it, or no matter how slow we went, it's like learning a new language. It's all new and different, and it can be very confusing, and you don't know, anatomy entirely. So it's kind of a lot at once, and we get that. So we're going to go through it slowly today to where you really understand why you're doing what you're doing, not just to do it, but to understand what it means, not only when you find something abnormal, but when something is normal, why it's okay, why it's not, and what we need to do about it at any rate. So what you want to really understand is the specific things in an assessment, even an unlabored, rate and rhythm, soft and non-distended, what those things mean. Because if they're not those specific things we're looking for, then they're the opposite of what we want to see, and that may mean there's a problem. So we're just going to start right from the top. As soon as you go into a patient's room, you've already introduced yourself, you kind of got a gist of what they've got there. You've got your set of vitals, I hope, reasonable vitals. Now you're going to begin your assessment. So when you go in there, try not to refer to them as their name. Almost every other time you want to do that. But when we do meds or when you do your assessment, one of your first questions is going to be, tell me your name and date of birth, right, with medications. So when you go in to assess their central nervous system, their mental capacity, that's when you have to say, tell me your first and last name. Now, I don't know how y'all drag like date of birth into with your assessment or the president or anything like that. There's none of that. What you're asking is their person, place, time, and situation. Those are the four things: person, place, time, and situation. So you're going to say, tell me your name, your first and last name, and be careful with these women that have been married 3 times. That means they have 4 names. So if you've got them written down as one, you might have to run through it a little bit or find somebody who knows, if they're a little out of it. And this happened to us once. We're given medication and she told us like 3 different names, and then she ended up giving us her maiden name. And none of those were on the chart. One of them were, but the rest of them were not. So we kind of had to get to the bottom of it. So tell me your first and last name. Then you're going to say, can you tell me today's date? And, if you're in the hospital and they're a 36-year-old female in for cellulitis of the foot because they flipped their RV in a creek that weekend or something, they should know today's entire date. When you're 86 lying in bed and they can tell you the year, run with it. It may be the best it gets, and that's okay. Then tell me, why are you here? What brought you here? And they should understand the situation to an extent. Now, in the nursing home, they may say, in skilled facilities, they may say, I live here, which is pretty legit. If they can tell you that they're in the correct city or county, that might be good enough. They don't always have to tell you the name of the hospital they're in. So you kind of have to recognize with their frame of mind what they do and don't know, and then adjust accordingly. Now, I'm very specific when it comes to those 4 things that they should know, right? Person, place, time, and situation. If they don't know less than 3, then you need to assess or have in your assessment their mental state. So I might say something like oriented to person and place only. Don't say times 2, don't say times 1, don't say times 3, because if it's not a 4, you're going to have to explain what those 2 or 3 or 1 things are anyway. So write the specific things they do know, not the things they don't know. and keep it simple. Less is more, but you need to be specific. So if they are oriented to person and place, but not time and situation, then I might say something like, they're calm and cooperative. They follow commands, maybe pleasantly confused, follow some commands with repeated prompting. It kind of gives the reader an idea of just how with it they are. So make sure you add that in there. Don't leave that alone. If they are completely combative or hallucinating or, swearing at you to get out of the room, that has to be in your assessment. And there's nothing wrong with quotes. I have quoted the F word before. If the patient swears at me, calls me names, and says specific things, I'm going to write down those specific things, and that lets the reader know the mindset. You need to say that. You can't say patient seems irritated. There's no seems, there's no kind of, there's no sort of, there's no appears to be. You have to be specific. If this goes to court, and remember what I always say, dance like no one's watching, chart like you're going to court. You have to chart these things to where if you are in that, on the stand, and you can say, this is specifically what she said. The patient stated, "You're a fat and ugly pig. Get out of my room. I hate your guts." That's what you have to quote. She doesn't seem irritated. She's livid, or she's completely out of it. At any rate, you have to write that down. Don't write a book, but make sure years from now you could reread that and maybe bring back that memory, maybe have an idea, be able to recall enough of that to where if you were going to court, you could be a legitimate witness, and you don't get to keep saying like, I don't remember, I'm not sure, I don't recall, or I can, you should be there enough. Your notes should be able to bring you back to an extent to that situation, depending on how long it is. I would want someone to look at all of my notes and say, don't call her to the stand. She's not going to help our case. She's going to make the facility look like they were on top of things. That prosecuting attorney is going to want to look for things to make you look like an idiot, to make it look like the patient didn't get good care, to make it look like the facility is at fault. So your notes have to be specific. You can't say patient sleeping. Okay, so any married woman knows that you could fake sleep like nobody's business, right? Even a quick little jerk, maybe a little, snore or a little sound in your sleep. Yeah, because if you have to fake sleep, you have to fake sleep. A patient can do the same thing. So what you have to say is patient resting quietly with rhythmic breathing. That kind of leads the reader to believe that it sounds like that patient's sleeping. You can't say the patient's sleeping because only you know if you're really sleeping. So make sure you're charting facts and not an opinion. And when you can back it up with subjective and objective data, it becomes fact. So when we're talking about their mental status, be specific. Then when we talk about their speech or anything like that, as you're asking these questions, your speech has to be in there. So if it's slurred, if it's hesitant, if they stutter, if they're unable to articulate what they're trying to say, but you can tell they're trying to say something, maybe they use flashcards, maybe they don't speak English or the language you speak, make sure you add that in there. Be specific. Let's say they're aphasic. So you would say awake and alert, assuming they, look at you when you walk in the room. Awake and alert, unable to assess orientation due to aphasia. Or patient has expressive aphasia. Maybe they can point or make sounds, but they're not able to speak correctly. Or they have dysphagia. They're speaking, but it's so slurred and so difficult to understand that you're not able to, really comprehend it. Be specific. You don't have to write a book, but you have to be specific. Make sure that anybody reading that isn't going to have questions. So like when I'm grading papers, if I say, okay, well, did she say this or did she mean this? Or, if I don't get a clear picture of it, or if I walk into the room to compare your paper with that patient, if there's any discrepancies, then your charting is not sufficient. So even if you have to have someone else read it or someone else go into the room and, kind of test it, there's nothing wrong with that. 26 years of nursing, I will still ask a coworker, does this sound okay? Read this note and see what you think. Does it sound like I was angry when I wrote this? Or, does it, because just like texting, I always use that example. One of my favorite episodes of Key and Peele is when they're texting back and forth, and the one's like, "Oh, hey buddy, I'll be right over," and the other one's like, "Oh, you come over." So the one guy shows up with a bat with nails sticking out of it because he thinks they're in a fight after this texting, because the written word could be very misunderstood. And the other guy, opens the door with open arms, he's like, "Hey buddy," and the guy drops the bat and he's like, "Hey," because he clearly misunderstood through texting. A lot of relationships could be in big trouble through things like that. So don't let it be in your charting, because that relationship could be between you and your license. So pay attention. So that's kind of the mental aspect. And I may come back to a couple other things when we're talking about your central nervous system. So after we kind of get to that, then you're going to talk about Perla, right? Oh, dear God, Perla. You guys, I don't know how this gets missed. I don't know how nurses in general, students especially, don't understand Perla. It's not just what it stands for. And I know all you students are like, oh my gosh, I remember the day she drilled this into us. It's not just that the pupils are equal, round, and reactive to light and accommodate. It's what do those things mean? What are we really testing with Perla? Recognize that that is neurological status, attention span, and visual acuity. It's not just that the pupils are equal, meaning there wasn't some trauma or some brain damage or something specific, that they are equal to each other, but that they were round, meaning they didn't have a wedge resection from maybe glaucoma surgery or previous injury or something like that. That also that they react to light, which means they should have some visual acuity to an extent at least, because that's a reflex. You can't stop that, right? So when you come on scene, or even in the movies, they pull the eyelids open and shine the light in, right? They're looking to see if the brain is there, if they're reacting to light. Just like when a CRNA and I are in the OR, well, years ago, I don't do it anymore, but we'd be kind of sitting there talking about our weekend, and she holds the little eyelids open, and one eye is kind of over here and one's over there, and they're not really kind of with it. They're not reacting too much. Well, then when they start kind of bucking on the tube, she checks the pupils and they're kind of back to midline and starting to constrict with the bright lights that are in the room. Well, she knows now she can pull the tube, because the patient should be able to be awake, alert enough to breathe on their own, and we're good to go to recovery. So it's the same thing here. Recognize what those words mean. Now, if you think they're not reacting to light, more often than not, I will tell the student, go close the blinds, pull the curtain, turn all the lights off, cup your hand around that eye, make it dark, turn the light on, your flashlight, and then as soon as you think it's dark enough and it's had time to dilate, move your arm, pop it in there, and you will see a reaction. If you don't, they more or less have to be blind in that eye, because that's a reflex. Even if they can't see well, you should see some reaction to that pupil. Whether it's sluggish or whether it's brisk, you still have to describe that. Also, if one eye is significantly different from the other, some patients are blind in just one eye, in which case you have to describe pupil by pupil. This is very common. A student comes up to me and they don't know how to describe it, and they've written Perla the first couple times. I'm like, for the love of God, if they're blind in one eye, there's no Perla at all. The pupils are not equal. So then you have to make sure that they're facing the same light. If the light is coming in from the window on this side, this pupil is going to be a different size than this one, because their nose is blocking, well, my nose anyway, is blocking the light, and this pupil may be more dilated, and because maybe these lights are off, or the door's closed and the curtain's pulled or whatever, you're not going to get realistic readings. So make sure they're facing the same amount of light. Face them towards the window, face them away from the window, whatever you need to do. Then determine that the pupils are either the same size if they're equal, or if they're different, then you're going to have to say so. You're going to have to say left pupil 4 millimeters, round, reacts to light, and maybe accommodation, we'll see. And then the right pupil is 3 millimeters and fixed, or 6 millimeters and fixed, which means it's not going to change. It doesn't mean that it's not going to move unless there was some sort of paralyzed injury or it's a prosthetic. Please don't write Perla when they have a prosthetic. It's like a ice pick to my heart, especially in history, when I gave you that they have a prosthetic and then you go and tell me Perla. Come on, man. So if that pupil is fixed and and doesn't react to light or accommodation, it doesn't mean it can't move. They could be blind in that eye. Where one eye goes, so goes the other. Not everybody can move one eye at a time. That's very unlikely, except for my girlfriend Jen. She can totally move it. She does this one thing with her fingers and she focuses, she makes one eye move. It's hilarious. But most patients can't do that. So make sure you're being specific with those pupils. If they have, any discoloration, or the cornea, is red or irritated or jaundiced or anything like that, they have that discoloration, make sure you're charting it there. Stay head to toe the best you can. I always kind of tell them, like, do like a laser pointer beam and, kind of start head to toe and don't miss anything. If they have alopecia, if they're significantly missing the hair, a woman is not often bald. So if there's any missing hair or they've got an incision with a bald area, that has to be in your assessment. So just kind of, laser beam, so kind of do it like you're an inspector, you're a detective and you're searching for anything abnormal. Really look. We don't do freckles, we don't do moles, anything like that. Now you got some, weird hairy mole bleeding over here, then you might want to mention that. So take your time and look over those areas very carefully. And Perla really matters. Make sure you understand what you're saying. So we know what pupils that are equal, round, and reactive light are, but accommodation. Focus, people. Accommodation has nothing to do with them crossing or following you around the room. That's tracking. And the crossing, I still don't know, the convergence or whatever that is, I don't know. You can, I guess if you're working in a neuro unit, you go into more detail with this sort of thing. I haven't, so I don't know anything about that. I'm not going to teach anything I don't know. I'm not going to pretend to know something I don't know. But when we talk about accommodation, that is the size of your pupils changing to accommodate for the amount of light needed to stay focused. Just like you would make accommodations at your house if your in-laws were coming to stay with you, right? You'd clear out the spare room, or you'd make your kids sleep together and clean one of their rooms, right? You would make accommodations to incorporate what's coming, right? The same thing with your pupils. Your brain is going to change, your retinal nerve and all the jazz that's back there that controls those things. It is going to change to accommodate for the amount of light needed to stay focused on the item in front of them, right? That's why I try to use a pen that has writing on it, or your pen light where it's got numbers or something on it where they can see and stay focused. So if you know they need glasses to see, or there's glasses on their bedside table, put them on the patient in order to do this correctly, or you are missing the point entirely. So have them focus on something that's got some numbers or letters on it that they can see clearly, and keep sharp lines to stay focused. And then you draw it away and you draw it near. So common sense would tell you, when you draw it away, they should, right, good, dilate. When you draw it near, they should constrict, because you should need less light when it's right here and more light when it's farther away, right? So your pupils will change to accommodate and bring more light in when something's far away that they need to stay focused on, and less light when it's up close. That is accommodation. Tracking is simply making eye contact or following you around the room or looking at you while you're doing the assessment. So if they look at you and they make eye contact and they're paying attention, even if they're not mentally there or anything like that, that's tracking. Maybe they don't have the attention span, visual acuity, or neurological status to accommodate. But if they can track, that lets you know that they're not staring at the wall, drooling, not making eye contact, not paying attention, because you know those patients, we've taken care of those patients. Those patients are unable to accommodate or track, which means they are mentally not there at all. They may not even know you're in the room, even as you're caring for them. So know the difference between tracking and accommodate. So if you can't write Perla, knowing that you can end it with accommodation, which kind of lets you know that they're there, which means stop charting that the patient is oriented to person only and can accommodate. I'm not saying it's impossible. I'm saying it's unlikely that if they don't know where they are, why they're here, or the year, can they really stay focused so much so that to have the attention span and to be able to follow those particular commands in proving accommodation. It's not impossible. And if you say it, then it needs to be true. But is it likely? So maybe not, right? So recognize what accommodation is. So if you write Pearl tracks, then I know that they didn't have the attention span, the neurological status, or the visual acuity to maybe accommodate, but they were tracking enough to kind of either follow, your pen if you put it side to side, or follow the cookie that you took off their tray, or that they were simply looking at you and they were able to track you around the room, and that they were at least, focused on you and realize someone was in the room, because we know that's not always the case. So that's your mental status, your Perla, your speech. Then we're going to oral mucous membranes. You don't have to count their teeth. while I find it very charming and hilarious, just it was one of my favorite things. 32 teeth intact. You don't get their teeth. I'm not saying that maybe there's not a time that if they thought there was a missing tooth that you want to hunt for it, but on average you don't have to count their teeth. Just that their oral mucous membranes are pink and moist, and then if they're not, if they're pale or dry, this may be the only time that you can put an intervention in your assessment, oral care provided, that sort of thing. And also that lets you know they also may be dehydrated. And careful in throwing your facility under the bus, because if they are truly dry and pale, that means that someone is not hydrating them. And people die of dehydration in this country as well as around the world. So don't make me get into my dehydration speech. Hydrate these patients, make sure they're getting enough to drink. So you may want to give oral care first. If you walk into the room and you see that there's an issue, clean them up first. If they're in pain, you're going to fix that first. If they're having difficulty breathing, you're not going to start saying, follow my pen. Take care of the problem first. If you see that they are sitting in their own feces, clean them up, take care of them. If they've got, significant thrush or their dry mouth or that white patchy tongue, clean all of that up first and maybe make a note if it's noteworthy. Then start your assessment. And I would assume that that's common sense, but I know common sense ain't common. So recognize that there should not really be any interventions in your assessment. You should have already have taken care of those issues, then begin your assessment once that's finished. So if you walk into a patient's room and they're like, oh, my back is killing me, you're not going to be like, oh, yeah, we'll get to that in a little bit. First of all, tell me your name, right? You would take care of that first and then do the assessment when they're capable of tolerating an assessment, because there's a little, poking and prodding, pushing and pulling and changing position. So if you went in there and they were short of breath, you wouldn't be like, okay, well, you'll be fine. We'll put your oxygen back on in a minute. Meanwhile, follow my pen. You would take care of those things first. So if you notice that there's stuff happening here, crusty eyes, all kinds of gross stuff, take care of that first, and then maybe go talk to the tech about that should have been cared for. Are they missing it? Do we need to talk to our supervisor and worry about that sort of thing? It may not need a note if it's something that could just be kind of cleaned up. If it's something significant, a pain note, a shortness of breath note, difficulty breathing, whatever it is, then take care of that, note it, and then go back and begin your assessment. And we'll talk about charting later. We'll do a bunch of examples of you walk into a patient's room and they complain of shortness of breath. They have, some sort of pain, and, how you would chart it. We'll go into that in detail. But right now, just your assessment. If they had any issues like that, you should be taking care of it. Then begin your assessment afterwards. So after we get to your oral mucous membranes, if there's any issues, dental carriers, that sort of thing, be specific. I know y'all like to use your, $5 words you learn in school that, I have forgotten. I basically just kind of say it as I see it and try to make it, as specific as I can without, going into great detail